I introduced myself a little bit earlier. My name is Natalie Sullivan. I'm an emergency medicine physician. I'm an assistant professor of emergency medicine here, so I'm an academician, and that is relevant because this is going to be more of a Socratic discussion than a lecture. We've learned that our medical students learn better if they're actively participating, so we're going to apply that today. I'm also the assistant director of our Disaster and Operational Medicine Fellowship at GW. So we focus a lot on training physicians to be not full emergency managers, because that's a whole different career, but to at least have that systems engineering mindset and take that approach to hospital preparedness and emergency medicine preparedness outside the hospital. So today, what I want to really draw down to is the nitty-gritty of how the policies that we've been talking about, the impacts that we've been talking about really affect you, your family members, any of our patients in the hospital. Because as a physician, you know, my number one is always going to be my patients, always going to be doing the right thing to not let them die in the ER. All right, so that being said, this is all going to be more from a hospital preparedness lens, and we want to work from the ground up to really get a sense of what are the real human impacts of disaster. Cyber attacks. Obviously, patient information exposure is an enormous problem, and I don't want to downplay that at all, but I think we're all really familiar with those specific impacts, so that's not the focus of today. All right, so who among you has recently been to the emergency department? Have you personally been a patient or taken a family member or had to stay in a hospital? Okay, so with that in mind, what touch points did you have with technology during your stay? I want you to think about your experience as a patient or a family member of a patient. How did technology touch your stay? Down to the nitty-gritty.
Admitting.
Right, admitting. Okay, so you're admitted to the hospital. That includes being triaged, getting put into the EMR. It also includes bed board. What else?
Med administration.
Med administration, perfect. So there are so many components of you getting a medication, right? I'm ordering a medication in the computer. Our nursing colleagues are getting the medication out of a Pyxis machine. They are taking your medication, they're scanning your wristband that you're wearing, and they're scanning the medication to make sure it is the correct one, and all along the pharmacists are watching to make sure that we're not overdosing someone. All right, what else? Vitals monitoring, okay, that's huge. No one is standing over you, particularly in the emergency department, watching you constantly, right? So you've got your monitor on, we have the screens next to us, they're gonna go off. We're going to ignore it for a moment, and then we'll respond when we realize it's real. All right, what else? Imaging, perfect. So you go down, you get an X-ray, you get a CAT scan. That order has been placed by a physician. You've gone down. The radiologist was able to retrieve the images from the machine that took your image. Then they're able to convey their read back to us, and then we're able to care for you. All right, anything else? Communications, that's perfect. So there are many layers of communications that we use. In the hospital, we have Tiger Text, that's an encrypted text messaging service. You have to have your cell phone. We have RF phones, we have radios, so there's different layers. I can tell you, when I experienced a cyber tech at a hospital that I worked at, we lost almost everything except for our personal cell phones. So what else? Insurance, yes. So the way we bill is through our documentation. If you are documenting on a piece of paper that you've never documented on before, you might guess that it might be different than your traditional documentation that you do on a computer. Yes?
Informed, I'm going to put quotes around it, informed consent, maybe electronic.
Yeah, absolutely. So informed consent, we actually are still in paper for that, so at our hospital, but there are many other hospitals who have advanced beyond us, we don't have that, who use all of that for their shared decision making, to really truly convey the risks and benefits. So, and I think you brought up an important point too with consent. When I'm consenting to a procedure in a hospital that's functioning normally, I can have a lot of confidence that things are gonna go the way they usually go. But is it part of consent during a cyber attack for you to acknowledge that a cyber attack is going on and there might be changes to a patient's care? Not currently. All right. Any other touch points? Yes, you guys are great. You don't need me.
Blood work.
Labs, blood work, that is huge, right? So, our downtime procedure for lab work is you get, well, okay, let's talk about good times first. Sorry, I'm getting ahead of myself. I order the labs, our technician will draw the blood. The blood will be labeled with a printed label that has the patient's name, medical information, and a barcode that also identifies the patient. That is taken by a tube system down to the lab, where the lab technician obviously checks it in, verifies that we have the right patient, it's going into the right record. The machine does the test, and then we get a printout that is an electronic printout that goes into the computer, and then I'm able to see in the emergency department. Yeah. I'm sorry, what?
Pre-hospital notification.
Yes, that's really interesting. So right now, most of our pre-hospital notifications are radio.
I couldn't hear him.
Oh, I'm sorry. The question was pre-hospital notification. So absolutely, most of our pre-hospital notification right now is radio. However, they also send us EKGs. So in order to see an EKG from the field, we have to have our electronic system working. Yeah. Interpreters. That is a really good one that people don't think about a lot. So thankfully we have some staff who are bilingual and who are official translators, which is different than just casually, speaking Spanish. And we use Globophone, which is on our cell phones, or we also have iPads that can do translation and also American Sign Language. Anything else? Yes?
Credit card reader.
Credit card reader. Actually, we don't really, in the emergency department at least, we don't do a lot of that. Thankfully for me, but absolutely, especially in other parts of the hospital.
Depends what GR you're in,
Oh, yeah, okay, that's fair enough.
Image capturing, so insurance cards, scan that into the EMR.
Yes, absolutely. So registration, and that's maybe you know what? I might be wrong. The registration people probably do get your credit card. The best part of emergency medicine is that we treat everyone who comes in the door, and we don't have to ask them personally for their insurance. So love that for me. But absolutely registration. All right. Yes.
Patient medical history, especially if the patient's unconscious.
Yeah, absolutely. So I work at both GW and at the Veterans Affairs Hospital, and while CPRS, their medical record, is the oldest piece of software ever used, you can see every single medical problem a veteran has ever had, and I cannot tell you how incredibly helpful that is. So being able to take care of a patient, knowing what their past has been, knowing what you can do for the patient that hasn't been already done, knowing what might be risky for the patient is enormous. And we get patients all the time who unfortunately cannot tell us about their medical history for whatever reason. All right, so you guys nailed it. There are many, many different ways that we've already gone over in which cyber affects the way that we care for our patients. And I got into this a little bit, but let's touch on how those things change during downtime. When we're going onto paper charts, we're talking about we're talking about a downtime procedure when everything around you is already changing, and then on top of that, you're having to go to a paper chart that you may or may not have experienced before, document on patients in a completely different way with very little background. And then you have to change all of your downtime processes. And I'm not going to get too in depth about that, but I think what we can all imagine is even if we've practiced our downtime procedures before, even if we have mechanisms in place to have runners go to radiology, have runners go to the lab, even if we have prepared the best we can, we're always going to lose time. So throughput is a measure of quality in the emergency department for many different reasons. We're constantly graded on our left without being seen rate because it's reflective of how long people are waiting, and it's reflective of missed opportunities to care for people. We're constantly talking about our door-to-doc time, our door-to-specific procedure time, and the reason that we talk about those things isn't just so that CMS can, taunt us with these numbers. It's because they're tied to patient outcomes. So, what diagnoses do you know of where the outcome is specifically tied to a timeline? Stroke, absolutely, right? It's 4 hours within onset of symptoms that you have to receive thrombolytics, so clot busting medication. What else?
Door to balloon.
Door to balloon. So when we say door to balloon, for those of you who aren't in medicine, we're talking about the time you have from the diagnosis of a heart attack to getting a balloon placed in one of your coronary arteries to stent open the artery. So it's your door to stent time. Okay? What else? Any other times you know of?
Golden hour of trauma.
Beautiful, the golden hour of trauma. Okay, so there is a lot of literature to support that within the first hour of your traumatic event, certain measures can be life-saving, right? So your outcome depends on that first golden hour that you're treated. Another important one is the 3-hour sepsis bundle. So if you come in with a really bad infection, you need antibiotics, fluids, resuscitation within 3 hours in order to improve your outcomes. And that's starting to become part of how we are paid. So not to say that this is at all financially driven, but the reason that it's now being tied to our pay is because it's a quality measure, right? All right, so I think we've really, oh, sorry, go ahead.
What about something like acute kidney failure or something, right? When
Yeah,
you come in the
so
emergency room.
So I think you bring up a really good point. The reason I put those up there is because these are like tried and true exact time markers that are tied to quality measures. There are so many other medical diagnoses that are clearly time dependent that we just don't have a set time limit for. So absolutely, if you're an acute kidney injury and you don't get the type of management that you need in a timely fashion, you could end up on dialysis, right? Like, this is not a little thing. All right, so we're kind of talking so far about the individual patient journey. We're talking about you, your mom, your friend who's in the emergency department and the way that they would be affected during an attack. But I also want to talk about it on a different scale. So those are specific ways we can directly see cyber reaching us personally. We also want to think about the hospital as a whole and then the hospital within a community. So what are some ways in which cyber might affect critical infrastructure of a hospital? Yes?
Well, it was like what Nate was talking about earlier. If you run out of your cash on hand, your hospital folds or gets gobbled up.
Totally.
So there's, kind of an end state to this.
Absolutely, yeah, so that's definitely true. I think I wasn't clear with my question. I'm thinking more like utilities, physical infrastructure. But yes, absolutely, business continuity is an enormous part of this that I can't even get into. Yeah, Nate?
Well, your pneumatic tube system isn't gonna be running your labs and stuff back and forth.
Yeah, absolutely, no pneumatic tube system. We replaced those with a lovely woman named Cheryl during my experience. And she would run back and forth, and she was super happy to be there and was not related to medicine at all. It was quite a relief. All right, so other things I'm thinking about are things like your water supply, okay? So we know that there's potential threat to water, and I think we sort of know that we need water to run a hospital, but why? What does water do in the hospital? Yeah?
Your chiller system, the air conditioners.
That is right, HVAC. We depend on water for that, yes. Sanitation, absolutely. We're all about sanitation in the hospital, right? Foam in, foam out. People are living in the hospital. We need to be able to bathe them. We need them to have basic hygiene. We need to wash wounds. We need to sanitize the hospital itself, right? We need to deep clean when constantly the emergency department. You wouldn't know it from looking at it, but yes.
Dialysis.
Yes, dialysis, that's a huge one. I think people forget that one a lot. We have to have water, we cannot do dialysis. Mixing drugs, yeah. We usually, and for that too, we need like sterile water. What else? Cooking, right? We need to feed the patients. They have to eat, just like you and I. We also need to feed the staff. All right. So we also use it for our sterilization equipment, right? So we sterilize the lab tubes. We sterilize items in the pharmacy, basic sanitation, food service, fire suppression, right? So I pray to God I'm not working in a hospital the day we lose water because of a cyber attack and then there's a fire. But if there was, we wouldn't be able to deal with it. And it actually is a place that's high risk for fire, right? The walls are full of oxygen, and we use tools to purposefully burn things. So you never know. All right. And then we have to think about the impact. I'm not gonna give this away. Ooh. Then we need to think about the impact on the hospital if the whole community loses water, right? So then we're not just talking about infrastructure problems, we're talking about what happens to the hospital when we have to suffer the consequences of our entire community not having access to water. So we're talking about foodborne illness, waterborne illness, we're talking about severe dehydration. In that scenario, we're competing with everyone else who's lost water for that water supply. And then we also have to ensure our staff is going to come in if they don't have water at home, right? So one thing we always have to keep in mind is when a disaster is happening outside of the hospital, we're gonna need people to keep coming to work. So how do we make them and their families feel safe so that they'll come back and work for us? All right, power outages. This is something that comes up a lot when we talk about emergency preparedness in a hospital, because I think most of us who've ever worked in a hospital have at some point experienced power outage. What happens when power goes out in the hospital? It gets very dark. The ER has no windows.
You hope your generator takes on.
Exactly, yes. And we have multiple generators. However, they only last so long. So, the red plugs, yes, yep. So the red plugs are the only ones attached to the generator. So if you're in a hospital and the power goes off, you're gonna wanna make sure right away that your ventilator is connected to the red plugs. Not you personally, but your family member has checked the red plug. However, I read a statistic last night that they think that the average amount of time across hospitals that a generator would last is 8 hours. Obviously, there's a lot of variability in people's generators in the hospitals, and we've already talked about rural access hospitals probably don't have the same generators that we have here in a massive tertiary facility. But just keep in mind that it's not forever. And once the power goes out and we don't have the red plugs functioning anymore, then we have to think about how we're gonna keep the ventilators going. Honestly, what we would do is we would have to have our medical student breathing for the patient until we get a better solution. That's what would happen. But we have other critical machines like a balloon pump. A balloon pump is literally a patient's beating heart, okay? Then we have what you've already brought up, lighting. The HVAC system, once again, would be down. There's so much other general equipment that you can imagine needs electricity. Refrigeration, a lot of our medications need to be refrigerated. There's no pressure in the water system without an electrical system. And then we have access issues. We'll talk a little bit more about that. And again, dialysis, not gonna do it. So what happens to the hospital when everyone in the city has lost power, or even this immediate area has lost power? Chris?
You'll have a number of things, but because they know hospitals generally have the backup power, people who have medical devices at home will start showing up at the hospital.
Absolutely. When all the power goes out and this is the only building with the lights on, they're gonna know where to go. And we want them to get help if they need that immediate care, but we're also gonna get a lot of people who maybe don't need emergent electricity. So that's what I mean by it becoming a safe haven. If the whole community is infected, that also means that we're competing for the fuel that's going to make the generators continue working. A lot of outpatient care becomes inpatient care. So if if you have a nursing home and you have a number of either ventilator dependent patients or patients who are dependent on some kind of device and they're not working, those patients are coming to the hospital. All right? And once again, we have the staff issue, right? If you're at home with your family and there's an issue with the power, are you gonna come to work? All right, one thing that we don't talk about much is security. So most hospital systems now are badge access, right? So I cannot get into the emergency department without my badge. I can't get into most of the hospital without my badge. Obviously, we can shut all that off, but then the hospital's completely insecure. Hospitals are one of the most violent workplaces in America, and it's not a fun place to be if there's no security. So other things to keep in mind, the electronic security system is how we guard babies. So if you've had a newborn baby, they put a bracelet on your baby to make sure that it cannot leave L&D without you. So that would work. Almost nothing is lock and key anymore. They're almost all badges. Constantly locking myself out of the VA emergency department by accident. All right, and so finally, another problem in the community that could potentially be cyber driven that would affect our hospital would be transportation. How do you think that would be?
Well, if your staff can't get into work.
Right, that is a huge one, right? If our staff can't get into work, we can't make the people work for 72 hours straight. We can try.
Or ambulance.
Exactly, yep. We're not gonna be able to get ambulances, or we're gonna get all the ambulances.
Right.
We're the one area that's accessible. Okay? Other things that you have to keep in mind, supply chain, right? Transportation is how we get all of our supplies. It's how we get our staff. It's also how we get transfers from outside hospitals. So we have a lot of hospitals, given that we're a tertiary care center, that send their very sick patients or very injured patients to us. They're not going to be able to reach that tertiary care if our transportation systems are affected. So, just major take-home points that I would like you to take away. Obviously, modern hospital systems rely on technology in order to deliver the standard of care. Cybersecurity threats compromise patient safety beyond just the exposure of information, which is very important, but it can affect critical infrastructure, and most importantly, it can affect you and your loved ones. We're talking about people's lives. We're talking about your friends, your family who are coming to the hospital for care. And that's all I got for you. Without further ado, if you have any questions, let me know. Yes.
I really enjoyed meeting you and your colleagues. What else do you do? You run,
The thing I was super excited to hear from you was that you do far more preparation than, it's a large organization here, it's beautiful. And it seems like you lady doctors are rocking it out. I love that you're in charge of that. But what else do you do? Because I feel like so many other hospitals are so far behind what you guys do to prep for such an occasion. So if you could just give a quick little.
Sure. So we're really lucky in that the CMO of our hospital, Bruno Petno, is an emergency manager. And he is a mentor of mine. He was our disaster director a while ago. We were really lucky to have him during the pandemic and now. So we have a hospital preparedness disaster committee, and we run regular drills, not just in cyber. We're doing one on chemical exposure and decon in a few weeks. But we have kind of a regular cadence of that, and we have an emergency medical plan. And actually the NCR is obviously very preparedness driven. And so we'll do citywide drills on Ebola or power outage or whatever have you. So we're really lucky to be a place like that. And I have to put a shout out to my fellows who are over here who have finished emergency medicine training and who are dedicating 2 years to learning about this so that they can take it on in their future careers. But if any of our local partners are interested in collaborating, we're always super interested to work with everyone.
One of the things you could check into is your local healthcare coalition, because I work with a coalition, so I know Bruno really well.
Yes, and Drew, I think.
Yeah, you'll have citywide exercises
such as we just had a modified delivery of care where we pretended there was a 6.9 earthquake that hit the whole area, and how do you deal with healthcare that way? But your coalition, they're looking at avenues to do more exercises, and they want to help you do that, so that might be a way to reach out to them.
I'm not sure there is one.
Every state has them because they get if you look through the hospital preparedness program through
Oh,
ASPR.
do it, thank you.
Yeah.
Hello.
Hello.
So has there been any thought around leveraging, I guess, clinicians in the event of a cyber attack to help? For instance, maybe it's just pulling the plug on a workstation or some instance like that. Has there been any thought around that?
I want to make sure I understand the question. So you mean like training, unplug your computer,
So, yeah, I'll give you
don't
a
make it
scenario.
worse?
So, let's say, unfortunately, a hospital was hit with a ransomware attack, or what appears to be a ransomware attack. Has there been any training or thought or discussion around potentially leveraging clinicians as a force multiplier to maybe, go and simply pull plugs on workstations or any type of medical device that may be at ground zero?
That's a really great idea. We personally have not done that, but I think that's a fantastic concept. I would say a lot of our training is really more focused on what do you do after boom. So in terms of like the clinical care, so how are we making these downtime charts that make sense? I know Nate mentioned the trifolds working a lot better than some of the newer forms. We kind of had a similar experience. And how we're gonna best mitigate during downtime, but I think that's a really great concept because I can tell you, I am not a cybersecurity expert.
Well, that's disappointing because I used to be the CISO at Tufts Medicine, where I think you trained at
Yes.
Jeff Online. So
Yeah,
my
absolutely.
training
No
clearly
way.
didn't work. Yeah, sorry.
No.
Yeah. Anyway, thanks. Awesome talk. So there's been a lot of talk earlier about this whole concept of secure by design, which is basically like security of products or services that people use are secure before they're anything else. And there's a lot of emphasis on like supply chain, people to kind of take care of that before stuff arrives. I'm just curious if there's a role to be playing for like suppliers on the emergency management side of things. If you were to say, if more things showed up a certain way, we could be more resilient running the hospital, not just recovering the computers or defending attackers, but like actually running the hospital in the event of a degraded state. And I was just curious, like, have you thought a little bit about like if something was better tomorrow in that respect, what would it look like? And how would it make your job easier?
I just want to make sure I'm understanding the question correctly. So I think a lot of what we do is more along those lines. So I know I'm never going to be like solving the actual nitty-gritty problem of the cyber attack, right? I'm going to leave that to the experts. So how do we make our process more resilient? And so part of that is with the supply chain, a lot of that is preparation, right? So Bruno, before the pandemic happened, ordered like 100,000 N95, so we just happen to have sitting in our basement, right? And so when we talk about preparedness from our side and resilience of our regular state, it's having those supplies ready to go, knowing which ones we're gonna want, and when we're on downtime, we're kind of using different supplies in a different way. So having a clear downtime algorithm that everyone's practiced and everyone knows, and does not involve a fax machine, it is how we are trying to make the approach from our clinical side. Does that make sense? Does that answer?
No, it does. I mean, it's just, there's so many things that we want to use to make computers more resilient.
Sure.
I'm thinking what are the things that we could be making just the facilities themselves?
Absolutely, and that's really more of our focus because I can't make a computer more resilient.
All right, let's thank Natalie for that amazing Socratic process.